Welcome to the EMT Pro podcast, where we deliver relevant content from the field in the classroom each month. Episodes of this podcast can get you 1 full hour of CE through our partner, emt-ce.com, so head over there for more information. I'm your host, Steve Williams. With me, as usual, is Dan and Holly. Guys, welcome back.
Hi, Steve. How are you?
Hello.
I'm good. How are you guys doing today?
Wonderful.
We're all coffeeed up, caffeinated, ready to roll.
Yes.
Yeah. Really kind of not just cool subject, but state-of-the-art stuff going on. And I'm excited that it's our very own Holly Ilg that is
Doing
the one
it.
running it.
Yeah.
So,
Great. Now people know my last name.
oh, do you not want me to tell people your last name is Ilg, I-L-G?
And I live at my social security number is.
Yeah. Holly is doing some really cool stuff in the field at the moment, focused on substance use disorders, and it's a study on buprenorphine for people who are addicted to opioids. And I'm going to stop there and let Holly completely run with it and give us the info, and then Dan and I can just throw some questions at you. But this is exciting stuff.
Give you the rundown?
Yeah.
Well, we're not the first place to do it. California has a huge program where they started doing EMS Administered Buprenorphine, or Suboxone, as you've probably heard of it before.
I can say that much better.
But
Suboxone?
California does not have Holly Ilg.
They do not.
Just
And
wanna
they
reiterate that.
transport everyone to the hospital, which is not our model.
No, that's not what's necessary.
Yeah. So
Keep people out of the ER.
Well, buprenorphine Suboxone is a lot easier to say, but the reason Suboxone is it a trade name or a generic name? You can edit this part.
No, I'm not even going to edit it. I'm going to look it up as we speak, and we'll just keep rolling.
I can't remember. I think it's the trade name,
'Kay.
right? So it's buprenorphine with Narcan, naloxone.
Okay.
And then buprenorphine can also just be by itself as just buprenorphine. So that's why you might hear different things. Brixadi is another version of it. It's an injectable form of buprenorphine, which lasts a little bit longer. So you probably have heard a lot of those things being thrown around.
So brand name is Suboxone, and Suboxone is, like you just said,
The brand
combo
name. I always get those mixed up.
of buprenorphine and naloxone.
Mm-hmm.
Other brand names out there, Zubsolv and Bunavail.
Ooh.
So I don't
I
know
haven't heard of those before.
I'll wait for my question when you're done. Go
Okay.
ahead.
I guess we can start, the reason we're doing this is because everyone knows we have a fentanyl crisis in America, probably around the world, I'm not sure. But in Oregon, from 2019 to 2021, there was a 600% increase in overdose deaths.
Do we want to talk
Jeez.
about what's likely contributed to that, or especially in Oregon?
Sure. I mean, the influx of fentanyl for sure. That's been a huge part of it. Obviously, between those years, we had COVID. During COVID, people weren't able to access their prescriptions. They weren't able to access their mental health providers, primary care providers. Everything just kind of shut down. So I'm sure that contributed also.
And then we had that law that went into effect that
All right.
changed,
Decriminalized.
small amounts of
Measure
Hard
110.
Yeah, Measure 110.
This is not a political show.
I know, and I don't want to
However,
get political, but
I would
that
like to plug
definitely-
Measure 110. It had
Yeah.
a great research behind it.
Yeah.
It had great intent behind it. They could not have ever imagined COVID was going to happen right after Measure 110 was put into effect. Also, just an unintended consequences of writing a bill is that when it gets voted on, it has to immediately go into effect. Measure 110 included funding for standing up recovery centers
Yes.
and places you could go. Those didn't exist yet.
Yeah.
So I think now, through COVID, now they're starting to exist. Now that funding's coming through, but it never really got off the ground. So now the talk is to reverse it.
And where are we
The-
on that? Did the governor sign?
Yeah, they repealed it.
They repealed it. Okay.
Has it
Which is-
officially gone into effect, the repeal?
I mean, I think it just happened last week.
Yeah.
Okay.
So
But the background on Measure 110, just to kind of give a few bullet points there. It was also known as the Drug Addiction Treatment and Recovery Act. When they passed the ballot measure, the people of Oregon recognized that drug addiction and overdoses are a serious problem in the state. Oregon needs to expand access to drug treatment, and it's a health-based approach to addiction and overdose, which is considered more effective. There's studies behind that, which Holly was just saying. And it's considered a more humane and cost-effective way to approach the overdose epidemic than criminal punishments are.
Right.
Making people criminals because they suffer from addiction is expensive, ruins lives, and can make access to treatment and recovery more difficult. But the thing that we noticed out in the field was all of a sudden there's this influx of overdoses because, I mean, we essentially took away the ability for police to police a lot of these issues. And so they just kind of had to turn a blind eye. I remember talking to cops about it when it went into effect. And then seeing because there was that lack of resources right away, it's like it just became this snowball that they never really got in front of.
Yeah.
And it just kept building.
Yeah, and there's a saying that we can't arrest our way out of this, and that's true.
Right, 100%.
You can't arrest someone for their chronic illness, which opioid addiction is a chronic illness. And so it needs to be treated as a chronic illness, not just as a bad time
fix.
in your life or a quick fix.
Yeah.
You know, and with the fentanyl influx, that changed the whole landscape of the drug problem, I guess, that we have. It's in everything. It's in meth. There's a lot of unintentional overdoses. Like maybe you're taking an oxycodone and you don't know it's fentanyl. And so some of those overdose deaths are attributed to accidental overdoses because they don't even know they're taking fentanyl.
Right.
Yeah.
It's in the meth supply. It's everywhere.
Man.
And
Yeah,
it's
it's a
so
big deal.
potent, you know, that just
And
a
so
tiny
cheap.
bit. And so cheap.
So cheap.
And it's interesting the way fentanyl works is that, you know, you're getting high multiple times a day because you're going to go into withdrawal. But the more frequent use of fentanyl, the more it builds up in your fat. So it actually starts acting like a long-term pain reliever.
Oh, wow.
And so when you do get reversed with Narcan, for instance, you're not just reversing it for right now. You're reversing it once that Narcan wears off. You know, you still have all this fentanyl in your system. Or once you do give the Narcan, the greatest risk of death is within the first 48 hours after
I've
Narcan
heard that.
administration.
Yeah.
So that the non-fatal overdose, most of ours, I think 40% are refusals.
Yeah.
Like you get reversed by a bystander or EMS. They refuse to go. They run off. They walk off. They're not even there by the time you arrive. And if you think about like their risk of death and that the next 2 days is really high, we just, you know, it's no wonder that we have a higher overdose rate.
Yeah. I just looked up, just so we can kind of cover all aspects of this, some fentanyl facts from the CDC. Fentanyl is a synthetic opioid. It's up to 50 times stronger than heroin and 100 times stronger than morphine. Street names for fentanyl are Apache, Dance Fever, Friend, Goodfellas, Jackpot, Murder 8, Tango and Cash.
Blues.
All sorts of names. Right now, over 150 people die every day from overdoses related to synthetic opioids like fentanyl in the U.S.
And that's a preventable death. It's like
Exactly.
no one should die from an extremity injury.
Yeah.
No one should die from an opiate overdose.
Yeah. Signs and symptoms of overdose, again, just to cover this stuff. Small constricted pinpoint pupils, falling asleep, changes in mental status, slow, weak, or no breathing, choking or gurgling sounds, body goes limp, cold, clammy, and or discolored skin. Again, this is off the CDC website. But, yeah.
So probably all the listeners, if they work in EMS, have seen an overdose.
Mm-hmm.
But with all the harm reduction, and listen, I've been in EMS for a long time. I've never really been in the substance use disorder world until the last couple of years, and it's very fascinating to me. And so a lot of my own biases and things I thought, I've changed my mind a lot on a lot of things.
Yes.
Harm reduction, for one, giving people a safe site to use, giving people materials to use that are clean, providing needles, just being vulnerable here. That to me felt like enabling. But really, what you're doing is reducing the harm to themselves. You're reducing their hospitalizations. You're reducing the risk of sepsis, disease, communicable diseases. And so looking at it from a harm reduction lens is you're still keeping people safe.
They're going to do it anyway.
They're going to do it anyway. It's like condoms with kids.
Yep.
Just because you have condoms available doesn't mean they're going to have sex.
Right.
So I try to keep, because that makes sense to me.
Yeah.
And so I try to think of everything on those terms. But from a harm reduction lens, if we can get buprenorphine in people's hands and we can explain the pharmacokinetics in a few minutes, then that is going to save lives. Buprenorphine reduces opioid deaths by 62%. And that's a huge number.
Yeah.
There's not very many drugs on the market that have that.
Yeah.
Methadone
no,
also. Methadone's another one that reduces risk of death by around the same number, around 62%.
So just looked up some more synthetic opioid overdose facts. Nearly 288,000 Americans died from an overdose involving synthetic opioids other than methadone between 1999 and 2021. So what is that, 12 years? I'm sorry. Do math, Steve. 22 years. Overdose deaths involving synthetic opioids, excluding methadone, in 2021 were nearly 23 times the number they were in 2013. So just an 8-year gap there. It went up 23x.
Yeah, and in Oregon in 2019, the unintentional opioid overdose deaths totaled 280. And in 2021, it was 745.
Wow.
And the data on the OHA website in 2022 only goes until May because it takes a really long time for the medical examiner to prove that it was an overdose death. By May of 2022, it was 332. So you can see that trend, that upward trend, that factors out to be that 600% increase. It's just so high.
Yeah. So tell us about what you're doing with this study and kind of what the goals of it are. And if you could wave a magic wand, what you would like to be seeing EMS providers doing in the field more.
The magic wand?
Yes, the magic wand question.
The magic wand. Okay, so buprenorphine works because it's a partial agonist. So if you think about your biology days, you have agonists and antagonists. And the antagonists are something that's going to block a receptor. So it sits on the receptor, and that's what Narcan is. It's an opioid mu receptor antagonist. So it sits on that receptor, and it blocks any other opioid from sitting on that receptor. And then you have agonists, a full agonist, which would be like heroin or methadone or any other opioid. It's a full agonist, so it sits on that receptor and gives that full effect that receptor can give, which would be euphoria, respiratory depression, the pinpoint pupils, all the things.
So could you dumb this down for me just a little bit? So the bup, you said, is an antagonist.
The buprenorphine is a partial agonist. So if you think of those two extremes, you have the antagonist on one side that blocks the receptor completely.
That's naloxone. Yeah.
And then the agonist on the other side that acts like it activates that receptor completely, like heroin, fentanyl, any opioid, because the mu receptor is the opioid receptor. A partial agonist would be like somewhere in the middle. Like if you have a light switch and you put it on a dimmer and you put it maybe like halfway to the brightness level,
right?
That's what buprenorphine does. And so because it sits on that receptor, it actually has a higher affinity for that receptor than fentanyl or other opioids, which is good.
Yep.
So it's going to sit there and give you, if you're in withdrawal, for instance, it's going to take away your withdrawal symptoms. It's going to help you with the sweating, the yawning, the nausea, the vomiting, diarrhea, all of those horrible withdrawal symptoms. But it doesn't give you the respiratory depression and the euphoria that a full agonist would. Does that make sense?
Totally.
Yes.
So if you're taking buprenorphine, you can drive your kids to school. You can have a job. You can do whatever you want to do. And you can take it forever. You don't have to just take it until you're, quote, over your addiction. Because remember, addiction is a chronic illness. It's a brain disease. And so if you can take buprenorphine forever. And unlike methadone, which is a full agonist, that can give you the full meal deal. You can easily overdose on that. You don't have to go stand in line every day at the clinic to get your methadone. You don't have
The
to.
embarrassment that causes.
Right. And think about like, how much time do you have during the day? If you have to get to
Right.
work, you can't go stand in line for 2 hours. But if you have your kids with you, you have to get a babysitter. You know, like there's a lot of barriers to getting it. With the buprenorphine, you can walk into a clinic, tell them you want Suboxone or buprenorphine, and they send you home with like a week's worth, you know, and then you can come back and, you know, speak with your doctor, and then you can get up to a month's worth, and then from on and on. Sometimes you can even just do a video visit and get your prescription refilled, depending on how you're doing. So
how
making
does it
it
work?
very low barrier is the key.
Gotcha.
So how does it work with your program? Let's say Joe Blow, he has an overdose.
Right. So we have some parameters because with buprenorphine, you think that it's a partial agonist. So if there's fentanyl on the receptor, it's going to kick the receptor off, or kick the fentanyl off that receptor and sit on it instead. So now going from the full effect of fentanyl to only partial effect, you could actually put them in withdrawal doing that.
Sure.
So the parameters are, you have to be, for our program, you have to be 18. You have to be in withdrawal, obviously. And we use the COWS scale, so you can look that up if you want. It's like kind of like a GCS, but it's for withdrawal
COW?
symptoms. COWS, the Clinical Opioid Withdrawal Scale. And it gives you a number. So you can go through and it has things like yawning, piloerection, which is fun to say, or goosebumps, sweating, runny nose, vomiting. So you can score people from like 0 to, I can't remember how far up it goes. So that's what our
11
medics do when they get on
scale.
scene, is they're going to first talk with them, figure out if they're on withdrawal or not, and then they're going to do a COWS score. And for our program, the COWS score needs to be 7 or above, which is pretty low.
Okay.
And the reason you need a COWS score is because they have to be in a certain stage of withdrawal to give the buprenorphine without putting them in withdrawal. Does that make sense?
Mm-hmm.
So
somebody already gave the Narcan.
you're golden. You're probably going
Okay.
to be like a 20
Okay.
or more if you
Okay.
just had Narcan.
Just to give the score, 5 to 12 is mild, 13 to 24 is moderate, 25 to 36 is moderately severe, and more than 36 is severe withdrawal.
Yeah, and so if you get on scene and someone's already been given Narcan, they are in withdrawal. Like, you've done it. You've precipitated with that withdrawal. We don't need to worry about it. And then, of course, they feel really horrible.
Yeah.
Because I don't know if you've seen someone in a withdrawal before, but it's miserable. And
Especially with the amount of Narcan the public is giving the people.
that's a whole nother podcast. People are giving
Yeah.
like 32 milligrams.
Yeah.
You know, they're basically drowning people in Narcan. But that's a public education thing we need to do. And at least people are giving it.
Right,
You know,
exactly.
even now we hand out Narcan, and now people are like, oh, I don't need any. I have some. You know, so
Oh, man.
everybody has it, which is great.
Yeah.
And so, you know, when you get there and they've been given Narcan, they are in withdrawal because we know Narcan has a higher affinity for those mu receptors also than any other opioid, which makes it very effective. And so in that case, we can administer the buprenorphine. So if you have someone who hasn't been given Narcan, that's why it's really important to do that COWS score, because we want to make sure that they are in, and that enough of those receptors are empty that when we give the buprenorphine, we're not going to make it worse. And if you
Gotcha.
make it worse, the treatment is more buprenorphine.
Oh.
The treatment is just more.
Okay.
So if you come across people who are like, no, I've tried that before, it made me really sick, they probably just weren't getting enough. And, you know, back in the day, you would get like maybe 4 or 8, and we're starting out with 16.
Oh, wow.
So we're starting out with a pretty hefty dose just to make sure all of those receptors get saturated and we're not making things worse for them.
Yeah.
in
Last
that
thing you want
moment.
to do is turn people off to the one thing that can help them
Right.
Yeah.
what they've got going on.
Yeah. And there's so much stigma behind opioid use disorder anyway.
Correct.
There's so much stigma behind being houseless. There's a lot of stigma behind a lot of it. And so that's a lot of what's been faced. And I think that's historically why buprenorphine was given very sparingly I don't think that, but over the years, we've learned a lot about it, and now we know just give them a bunch.
Yeah.
And the cool thing is when people go home with it, the instructions are take what you need, basically. If you start feeling bad, take more. If you start having cravings, if you start feeling nauseous, take a dose. So, it's not without risk at all, but it's pretty low risk. Now, if you're going to take the buprenorphine with alcohol or something else, benzos, it's safer than doing that with fentanyl.
Yeah.
Right.
But you're still putting yourself at risk.
So they've got to be 18 or older, have the CAL scale above 7.
Mm-hmm.
What else?
For indications, they have to be able to consent.
Okay.
So they can't be sick otherwise, like have
Right.
sepsis or something, any altered mental status. So they have to be able to be awake enough to consent to the treatment. We had pregnancy as a contraindication, but we took that out because buprenorphine is very safe in pregnancy, and actually it's recommended in pregnancy. And so we took that out. I think that's pretty much it. They have to. So one of the criteria is they have to have a substance use disorder, and the only reason we put that in there is because if you have an overdose and you've been given Narcan, and you accidentally took fentanyl, this isn't really the kind of patient that we want to enroll in the buprenorphine program, because you don't have an opiate use disorder.
Right.
You just accidentally took something
Right.
in your meth or whatever
Right.
else that overdosed you. Or maybe it's the first time you've ever tried it. So if you're a chronic fentanyl user or opioid user, then that would be the perfect person. So we put that in there as you need to have an opioid use disorder in order to be part of the program. So it's pretty easy. We identify the withdrawal, ask if they want the buprenorphine, and then we give it. So right now, because it's a pilot, we're calling the Poison Center because there's a fellow there that's partnering with us for this pilot. And so we call them and just say, hey, we have someone with an overdose. This is what we're going to do. They're like, great, go for it. So it's pretty quick. And we give initial dose of 16 milligrams. And it's sublingual, and it has to dissolve completely in order to work. And then we can give an additional dose of 8 milligrams, and then one more 8 milligram to equal 32 max.
Wow. On scene. First time.
On scene, yeah. And usually, it depends on how they're doing. But, we're talking like we're on scene for an hour. This isn't just like,
Yeah.
rapid fire. So you're going to give them a dose and see how they're feeling. And then at that point, we're working toward getting them to the walk-in clinic, which we've made some partnerships with some of the clinics in town to see if we can get them in. And the purpose of the walk-in clinic is we don't want to it's great to give people buprenorphine and have it readily available and break down some of those barriers of getting it. But we really want people to go to the clinic and engage. So we want them to engage in recovery, which could look like you walk in, you need a prescription, right? Even though they'd probably be good now for about 12 hours, we still want them to have their prescription, for the next week or so.
Yeah. Lower the barriers.
Yeah.
That's awesome. I know that the one thing this has brought up for me, just listening to you chat, is just how jaded we are in EMS.
100%.
Yeah.
And I don't want to I don't want to make EMS providers out to be the bad guy, because we're often jaded because of multiple bad experiences. And when we're dealing with the side of the homeless crisis that has to deal with folks who are, a lot of times violent when we respond for various reasons, it's not an insignificant thing that, the people in the field have to deal with. But I think if we can put that aside and we can say, what is the data showing can be helpful in correcting this issue? Because it's not, as much as we want to make the fentanyl crisis, the houseless crisis, a quick fix, it's just not.
It's not.
One
There's
of
so
those
many
things.
layers.
There's so many layers to it. And so when a politician says, oh, we're going to fix the houseless crisis or whatever they say, it's always like, are you really?
Yeah.
Because no one's really done a good job of it yet that we've seen. And it's not a quick fix type of issue.
No,
Not if
and
you want to do it right.
no, and there's so few services available. Like we've got some great programs in the city, but the actual accessing those programs is really difficult. Like we had a client who we picked up, got the buprenorphine, took him to the clinic. Everything was working beautifully, but think about like we're 3 hours into this now. And the model we have is we have the paramedics are responding to overdose calls. They're initiating the buprenorphine. And then we have what's called an overdose support team, which is a nurse and a peer. And so then we'll go out and like assist them on scene so they can get back in service. And then we sort of like carry on.
Mm-hmm.
So then or meet them at the clinic.
Yeah.
So then we can sit there with them through their appointment. A lot of it is there's so much stigma and so much trauma around medical appointments and just the experiences they've had from medical providers. They don't want to go. Like they're afraid to go. And so if we can go and just sit with them through their appointment, we can administer more buprenorphine if they need it while we're waiting. And then help get them, hooked into the medical community. And we've got some really amazing services right now. Like Central City Concern is one of the places that we go, and they are fantastic. They treat people with integrity all the time.
Mm-hmm.
And it's really great. So, we sit there with him through their appointment, and then we got him. So now we're to the point where we're getting his prescription. We've actually got a place for him to stay for the night, which is very rare. And everything's going perfectly until we find out his insurance won't pay for it.
Mm-hmm.
Because buprenorphine is considered a physical health medication, not a behavioral health medication. And depending on what each insurance will pay for one specific thing. And I can get into this, but I've seen so many barriers where it's like, well, that's mental health. We're physical health. We're not going to pay for that.
Yeah.
And so
Yeah.
we got all the way to that point. So we're like, shoot, well, let's put him in a cab because he just wanted to go home at this time. He
Right,
wanted to
right.
go lay down. So we put him in a cab, sent him over to the shelter. And then we drove across town to pick up his prescription, drove back out to his shelter to drop it off. That took us 2 hours just to do that part.
Right.
And these are the barriers that everyone is seeing. And it's so difficult to like complete the process
Right.
unless you have other people to help you. And no one does.
Yeah.
And so had we not done that, he would have left the clinic and gone and used more
Be
fentanyl.
done.
So he went to his, so then finally we got him his meds and it all worked out. But every single call we go on is like that.
Mm-hmm.
There's always some hiccup that is, if you think if you're in crisis, the last thing you're going to be able to do is navigate getting in a cab. You don't have money.
Right.
To go pick up your prescription an hour away or whatever in traffic. And anyway, it's very difficult. There's so many barriers. So that's one thing we're trying to pick out with our study is what are the barriers? Everybody thinks they know what the barriers are, but honestly, the barriers are our system.
Right.
The system itself and all the red tape is a huge barrier.
Yeah. The insurance agencies in general are just.
And just
Yeah.
like because we're in this 90-day fentanyl crisis, the state of emergency, that's the only reason we got him a bed, somewhere to stay for
really?
the night. Yeah, because we've increased our capacity for shelter beds. I hope that continues. But so that's just one experience. And you can say like pretty much every experience has been like that. There's always been something that we've had to help navigate. And then our teams follow up for 90 days. So whether that's, going out to see them every day, sending text messages, making sure they make it to their appointment, and just try to let them know what to expect. Like, hey, when you go in for your follow-up, you're going to have to take a P test, which most people are like, nope, I'm not going to do that. But the P test is only to show that they're taking the buprenorphine. If you have benzos or something else in there, they don't care.
Yeah.
Right.
They're still going to give you your medication.
Right.
I think in the past, that was not the case. And then with methadone, I think a lot of times that's not the case. But it just depends on the clinic.
Right.
But in our area, it's so low barrier. They just want to know you're taking the drug. Maybe you're diverting it and giving it to someone else. But if it's not showing up in your urine, they're not going to be like, keep supplying you your medication.
Right.
Buprenorphine's not. It actually costs more on the street than fentanyl.
Oh, really?
Yeah. So that's the information I have. But if you're diverting it to your buddy, I don't see anything wrong with that. Almost
Right.
like great. It's better
Yeah.
than
Better than the fentanyl.
taking fentanyl. Yeah.
How receptive are the patients?
So far, so good. I mean, I really thought so. And when California did this, and I can't remember what year it was, but I think they published it in 2021. Dr. Hearn, the California Bridge program, they had 38 patients in their first year that did it. So we were thinking probably 1 or 2 a month, maybe.
And that may not sound like a lot
Yeah.
to our listeners, but
Mhm.
that's a lot.
That
When
is a
you're
lot.
That 1 or 2 people.
Yeah. When you think of 40% of your calls are refusals or
Yep.
unable to locate, that's a lot of people. So far we've had 5 in a month and a half. And I think that's pretty good. And actually, we have a car downtown that actually specializes in running overdose calls right now. And a lot of the patients they were running on before we started the program were asking about it. Like, hey, I heard you're doing this. When are you starting it?
So they
Um,
want to get off.
That's a good question. So you also have to, everyone should look up Prochaska and DiClementi's behavior change model if you're
I'll look it
if you're a dork like me. But you think of like the stages of behavior change, and we've all been there. Like, let's say I'm going to start a new workout program.
Right.
I might stick with it for a few days, and then it gets too hard,
Yeah.
or I'm like, I can't be consistent. So then I like fall off the,
Yeah.
You talk about the trans theoretical model.
the trans theoretical model of change.
I'll put the link to that in the show notes.
It's a beautiful model because it starts with just being like getting familiar with the idea
Pre-contemplation.
of changing. Like,
Mhm.
thank you.
Yep.
Which is like, hey, Steve, have you thought about
No.
checking your blood pressure?
I haven't.
Oh, good.
Why should I do that? Holly?
Yeah. And I was like, that's cool. And then it goes through like, and then maybe they're like, oh, now I know about it. Now I'm kind of thinking about it, but I'm not going to do anything yet.
You're
So-
contemplating.
Yes. And
Contemplation.
then there's the next stage
determination.
where you're like, maybe I'm going to do something about it, but you haven't done anything about it yet. So we're thinking like we're 4 stages in before you actually start
Right.
taking action.
Mhm.
And the beautiful part of this model is that if you think of it as like a cycle or an upward spiral is how they refer to it, because you're always moving forward, is relapse is part of the cycle of change.
Yep, right there.
Oh, yeah.
So you have to expect someone, all of us,
Yeah.
to relapse at some point before we make this change that is permanent.
Mhm.
And maybe it's never permanent.
Yeah.
Maybe you're always in some sort of cycle of change. And then when you do relapse, you don't have to start from the beginning.
Yeah.
You might just start at the stage before.
Mhm.
You know, so I think of like
Wow.
my running, for example, is like, oh, I just ran an ultra marathon. I'm so great. And then maybe I don't run for like 3 months. And now I've got to start all over at like a 5K, you know, and it's like, but you're still, but I didn't start at the beginning.
Yeah.
You know, I didn't start with.
Right.
So if you think about all of our behavior, this isn't just for substance use disorder, but
Right.
they've done so
Change in
many.
general.
Yeah. It's an old theory from
Mhm.
the 70s. Actually, they have revised it over the years, but it works really great with like HIV, medication compliance, stopping smoking. So if we can sort of carry this vision with us when you're dealing with someone with substance use disorder, just know that when I ask you, hey, do you want to try this buprenorphine? That might be the first time.
They've
that-
even heard of it.
Right. They're like, you know, maybe they're in the pre-contemplation stage. Like, oh, yeah, I've heard of it, but no, I'm not ready. And that's cool. Great.
Yeah.
You know?
They're in the
Or-
cycle.
Or maybe we give them the buprenorphine. They might go to an appointment or 2 and then never show up again.
Yep.
And then the next time we see them, I mean, it should be like, oh, awesome. You're back. Thanks for showing up. We're so happy to see you, because they've done that. You know,
Mhm.
they did it. So I don't know. I just feel like that is a really huge part of it, is even if they're interested and try it, that doesn't necessarily mean they're ready to change, but we should give them the option.
Yeah.
Right.
For sure.
And just the benefit of the doubt that trying something different today, good on you. So out of our 5 patients so far that we've done an induction on, we only have contact with one of them. So everybody else is off the grid, like not even we're not running 911 calls on them. Like their names aren't popping up anywhere, so I'm not sure where they went. But I'm sure they will pop up again.
Oh yeah.
And maybe they're just out of the system for now.
Mm-hmm.
Maybe they found, I don't know, maybe they found shelter somewhere or went to a different state. I have no clue. And that's kind of what I expected.
Mm-hmm.
And so far, all of our patients are white, houseless males around the age of 30. So, which is also not surprising, given our demographic for Portland. For any like substance use disorder, that's kind of the age range in the statistics. So,
Are you hearing any common stories, common themes in their stories when you talk to them?
Not really. I mean, they're just all very disconnected. Like none of them have primary care doctors, of course, or housing. And it's really hard to think about changing your behavior when you don't have your basic needs being met.
Yep.
And so I feel like that's the common theme. But it could just be also where we're focusing our efforts, which is the downtown core area. There is a lot of houseless folks there. So maybe that's why so far those are the patients we've had.
Yeah.
So yeah, that's
How long are you guys going to do the pilot?
18 months.
18 months.
Mm-hmm.
And you're how far into it?
A month and a half.
Yeah. So 16 and a half left.
Yep. Which is kind of good. I mean, we've already learned a lot.
Mm-hmm.
Gotten some good feedback from the crews. We're trying to figure out what our barriers are. We are going to write a paper on it, so you'll see that in the future.
I mean, how many? My brain goes to resource allocation because at some point you don't have the capacity to run prescriptions across town for every single person.
Right. So that's exactly part of. So our model is very different. So the California model is the paramedics would arrive. Narcan had been given by someone. They give the buprenorphine. They transport to the hospital. Bam, done. And then at the hospital, they've actually developed these amazing programs with like patient navigators and nurses, like substance use disorder nurses, and they do all of their wraparound services from the ER.
Like full case management.
Full case management.
Wow.
And so, and actually, if you go to California Bridge, their website, they have so much amazing free training, and you can learn a ton about it. Their program is amazing. And actually, in San Francisco, their street medicine program just got $6.6 million
Wow.
to fund a program exactly like what we're doing. Except what they're doing is they're out walking around, basically like they have a provider on staff so they can write prescriptions, do, give antibiotics and things like that. But they're also, their main goal is the buprenorphine administration. So
$6.5 million sounds like pennies for.
Do you want to know what our
the
budget
benefit
is?
that they could do for this?
$380,000.
Dang, yeah. So you would love $6.5 million, but
but you know what that gets you?
when a
That
state is
gets you
spending money on
5
this?
people that can give buprenorphine. That's all. So
for
we have
$380,000.
for $380,000.
Yeah.
Because we budgeted in. It's mostly personnel, but they're not paying our salaries. This $380,000 is like on top of whatever's existing.
Right.
Mm-hmm.
It's the medication. We budgeted in for a data analyst, which happens to be me right now. So I'm not a data analyst, but we will get one.
Yeah.
And then supplies. So we've budgeted for cell phones, hotel vouchers, things like that. And we're still working those details out. So 1.0 version doesn't have cell phones yet, but we will soon.
So
And that's really important. The connection piece,
Oh,
I mean, for
absolutely.
everything we do in community health is the most important thing, is being able to access. I think we should bring back payphones. So then our patients can call us from anywhere.
amazing.
Like, because now there are no phones. If you don't have a cell phone, you have no communication.
Right.
And, we need a way for people to just be able to pick up a phone and call us.
Yeah.
Because they will. I mean, I get text messages from people all the time. I got a text just sitting here from someone we're working with that's like, hey, I can't remember when my next appointment is.
Mhm.
So, and if you look in the behavior change model, that's great.
yeah,
I mean, they're
Yeah.
actually thinking ahead that they
That's
have an appointment coming up.
Yeah.
yeah.
So, so I think the communication piece, and then just we have a shoestring budget. So It does include one paramedic salary, but that's the only salary it covers. But the goal of the pilot is to scale it to the entire county, so every paramedic will have buprenorphine on the ambulance. So they can at least do an induction. You know, once the study's over and we wrap it all up, we'll have to just decide what that end goal looks like. But that's the aim, is to be able to get it to as many people as we can.
Wow.
And the whole Tri-County area is watching you guys.
Clackamas County, we're in Multnomah County. Clackamas County started theirs a couple months ahead of us. It's also a very small pilot. We're looking for low numbers right now. We're not looking for thousands of people. Although if you think about Multnomah County, we run about 50 overdose calls a day. That's a lot. So I'm not saying we run that many calls, but that's how many come through the 911 system. And that's just the card 23 overdoses.
Yeah.
That's not the unconscious patient, the breathing problem, the seizure that end up being overdoses.
Yeah.
So Clackamas County is doing a very small pilot also. And then Washington County is just kind of
We're waiting
watching
for
and
your
waiting.
mistakes.
Yeah.
And I think we need to talk about a recent news agency that spoke to you about this, because that was a pretty big deal.
Yeah, you know, I really think that the culmination of, we already knew we were in a fentanyl crisis. Like, we've been in a crisis. We were in a crisis in 2016. We were in a crisis in 2020. I mean, we've been in an opioid crisis for a long time. But now it's getting a lot of publicity. The governor declared a state of emergency. And so it got a lot of attention nationwide. And it just so happened that this pilot program we've been building for the last year also started simultaneously with the state of emergency. Completely separate, but it just, the perfect storm. Which actually, sidebar, decreased our call volume, because once everyone stood up, the sweeps and the police presence, which they're all doing great. And the police officers that I talk to, they're not in it to arrest the users. They want to arrest the dealers.
Right.
So everybody's kind of being left alone. But with the show of force and all the people out and about, people are either going indoors. So we've seen actually a couple of slight increase in overdose deaths because they're indoors. And then, or they're going over to the east side, in different locations. So, but because of the state of emergency, like I said, there's a lot of attention on the city right now. It's also an election coming up, so there's a lot going on. But so we have had a lot of news agencies wanting to do interviews. So we did, OPB did a couple of interviews, NPR, and we did a big press conference, which I think is where, if you look at the news articles on Portland Fire, Buprenorphine Administration, most of that information is from the press conference. Some of it's not accurate, but and then from the city council meeting where we presented to the city council to be able to accept the funds to do this program. So
that's awesome. I'm just happy I know you.
Yeah, me too.
Why,
You're a pretty
thank
cool
you.
person. You're doing some cool stuff.
Yeah.
It is really cool. And I mean, Suboxone's been around forever. It's not new. It's just that EMS providers are being impacted and the community's being impacted so much more. I mean, if you think of, I don't know if these numbers are correct, but I think Station 1 ran like 700 overdoses last year out of one station. So you might want to fact check those numbers, but that's a lot of overdoses. And that's a lot of moral injury if you think about it, to the provider or to the paramedics and firefighters showing up and knowing they're probably going to refuse and there's nothing I can do. There's nothing we can provide them.
Yep. They've
just been given Narcan and feel like crap. Of course they're going to go get high again.
Yep.
Of course they are.
They've got nothing else to.
And of course they don't want to go to the ER. So that's another difference for this pilot, is that we don't want to take people to the emergency room because they're just going to sit there and withdraw and not be seen.
Get treated poorly.
Possibly, right? And it's not an emergency to the emergency room, right? and then they're just going to leave AMA, and then they're going to go get high, right? So what we want to do is, if possible, some people are going to have to go to the ER for lots of reasons, but we want to treat them in the community and keep them in the community and usher them to their community resources. You know, like help them get to the clinic, help them go to their follow-up appointments, help them get their meds. Like if we can just take that extra step, which honestly, I think that's what community health is being there to like bridge the gap, right, between people's homes and the clinics. It's a chasm sometimes. Just getting people to go to sometimes we work with people for months before they'll even agree to see the doctor. So, you know, if we had more telehealth, we do have a couple of telehealth options. OHSU's Harbor Clinic is telehealth only. So if we call them and they're available, they'll come out, give the person a phone, and they can do all of their substance use disorder treatment over the phone or over FaceTime. The problem is they don't do anything else. So if you have a substance use disorder problem, they're not going to give you your high blood pressure meds.
Right.
They're only doing that. And if you think about like the intersection between physical health and behavioral health, they're never separate.
Right.
I mean,
right.
Especially in our clientele, a lot of them are very ill. And so there's that option, and there's the walk-in clinic option. The detox option is less available, but some people do feel more comfortable doing it's not really a detox, it's more like a, what's the word I'm looking for? Like assisted withdrawal.
Yeah.
And, you know, so we have different levels of things for whatever maybe they're in their stage of behavior change where they're not ready, but they don't mind talking on the phone to somebody.
Yeah.
So that's the first step.
Still in the cycle.
Yeah. So, and then we will follow up. Again, like the very next day, we want to follow up as early as possible. We want to keep track of them, and frequent connection is really important. So if we follow up the next day, let's say they don't go to the clinic the day before after the buprenorphine administration, we'll follow up the next day and maybe give them another dose. But then we're capping it at that. Like that's all we'll do from the community perspective until you get to your appointment. Because otherwise we're just going to be the mobile buprenorphine, which I would love, but that's not the model for this particular pilot.
Right.
So
Yeah. So where would you point people to if they want more information on maybe not just what you're doing, but more information about buprenorphine in general, or
SAMHSA is a good website.
Okay. And I'm going to put all this in the show notes for folks. So.
They do a lot of substance use disorder. I mean, everything. They've got a ton of information on their website. California Bridge, I would call them the pioneers that really took this to the next level. And actually, I don't know how many sites now, but like dozens of hospitals in California now have adopted this model. And they, like I said, they've got some great free training on their website, lots of great videos. They actually do a webinar every month, which is really interesting to attend. It's all of the substance use disorder practitioners kind of get together and talk about what they're seeing, what kind of practice changes they're making, how fentanyl in particular is changing. I think everybody just wishes people would go back to using good old heroin because it was a lot easier to manage.
Yeah.
Because if you just sidebar is, if you are a frequent fentanyl user and you're in withdrawal symptoms and you give buprenorphine, you can still precipitate that withdrawal because now you have like a biofeedback system where you create more fentanyl receptors. So now you have more fentanyl or more mu opioid receptors. So now you have more receptors to saturate with buprenorphine. So it takes more and more and more. We were thinking 8 milligrams at first. Now it's 16. Some people are requiring like up to 64 milligrams to help with their withdrawal symptoms because it's stored in your fat. So you're having this like extended release of fentanyl in your system. So it's just really interesting to hear what's the latest and greatest out there. And like I said, California Bridge has a great program. I'm trying to say Dr. Hearn is one of the doctors. And then as far as Portland Fire goes, or just the chat team really is who has
What's the chat team, just so people know what that means?
It's the community health section of Portland Fire. We're funded solely by Care Oregon, and Care Oregon's also funding our buprenorphine pilot. So shout out to them for being innovative.
Right on. So, Daniel, I don't know about you, man, but I'm sitting over here going, you and I just aren't that cool.
We aren't that cool at all.
You know?
Not one bit.
Yeah. I think everything you're doing is just awesome, Holly. I don't really have good words for it, but taking the view of how do we actually make it better and then being a part of that solution is something just so few in our industry actually get involved with. So pretty awesome stuff.
I've found I've been a paramedic, I've been a nurse, and I've worked for institutions, it seems like, as a nurse. But once you get out in the community, there's so much work to do.
Mm-hmm.
There's so much work to do that's not being done. So if you're innovative and have ideas, I mean, this is the place to implement them.
But
Because
we work in such a reactive profession.
Yes.
Yeah.
That's all we do. I mean,
Yeah.
what you're doing is proactive,
Mm-hmm.
which is amazing.
Yeah, we're trying to be upstream about it. And, we'll be at the OPAT conference in Sun River at the end of April.
Nice.
So
That'd be a
that's
great
gonna
place for
be-
people to check you out.
Yeah.
Cool. Well, shoot, that was our whole episode. But we've got a lot of information in the show notes, so we're going to post a bunch of stuff there. So make sure you guys check that out. And then, we would love to hear from you individually. So if you want to write to our EMT Pro email address, email is info@emtpro.com, and send us stuff. We interact with listeners quite a bit. We get good ideas from people on what they want to hear for next episodes. And for the next little bit, we're going to be focusing on some case studies and getting some medics from all over the country just giving us a 20 or 30-minute snapshot of an interesting call. And would love to hear from you guys on what you're working on, how you're being proactive, what you're struggling with in the field, what's successful for you all in the field. So it's all relevant. We'll leave it there, and thank you guys for joining us today, and we'll catch you on the next one.